Good evening, everybody. On behalf of Canon Medical Systems, I welcome you to tonight's ultrasound webinar on fetal neurosonography. So wherever you are in the world, this will improve your skills. It will boost your confidence. And I'm sure that you might have any questions, and you will see our audience will be happy to share those questions and their answers with you. So we have three excellent speakers from all across Europe, invited Professor Laurent Guibault, Professor Luc Ducat, and Dr. Miguel Branco, for you to be here and to share their knowledge with you. As you can see, you are not alone. Even you might feel you so in front of your computer, but people, colleagues of yours from 86 countries all across the world are joining. So this is so exciting, and we will all enjoy this evening. So please welcome now Professor Laurent Guibault. He is not only a speaker tonight, but he is also a moderator. So now it's time to go and to say welcome Professor Laurent Guibault. He's a radiologist and professor of pediatric and fetal imaging at the Hospital for Mère Enfant, which is affiliated to the University of Claude Bernard in Lyon. And he's one of the leading experts in fetal CNS. Thank you very much, Laurent. Please kick off the session.
Thank you, Petra. Thank you for this kind introduction. Hello to everybody all over the world. It's nice to join you on the web. And on behalf of the two other speakers, Miguel Branco and Professor Luc Ducat, I want to thank Canon Medical System to have organized this webinar and to give us the opportunity to lecture on one of our favorite topics, which is the fetal brain. So let's begin with the first speaker. It's Dr. Miguel Branco. Dr. Miguel Branco is a very smart guy. I had the opportunity to meet him in Lisbon some years ago. And he's one of the most recognized experts in Portugal for ultrasound of the brain and also of the heart of the fetus. So he will give us the first talk about generality of fetal brain ultrasound from screening to neurosonography. So Miguel, it's your turn, and you will enjoy this lecture.
No, it will be work. I would like to thank the Canon team for the kind invitation and the nice words from Laurent Guibault. The topic of my talk is a stepwise evaluation from screening to neurosonography. The ISOG updated its guidelines recently about the screening and the neurosonography, and the screening relies mostly on two axial planes, the transventricular and the transcellular one. The transthalamic plane is used mostly for biometry. And why should we screen it? Because disease pathology with high incidence, neural tube defect is about 1 to 2 per 1,000 births, but other pathology with intact neural tube have a nice incidence that could be as high as 1 in 100 and are associated to long-term disabilities. The first part of these guidelines also give us the formal indication to neurosonography. We should be well aware of the different aspects of the fetal brain throughout the gestation, but for screening purpose today, I will talk mostly on the second trimester scan. The principal indication for formal neurosonography in daily practice are suspicion of fetal brain malformation and previous history, and also suspicion of congenital intrauterine infection. Neurosonography is a target examination which we have multiplanar evaluation in maturation and evaluation of maturation of the brain. We'll start with a transventricular assessment. In this plane, we should assess the head shape and the integrity of the bone, and also locate the coronal sutures and lambdoid sutures, which are our acoustic window. If we have a perimeter closure of one of these sutures, like in this situation, the coronal one, we have a loss of visibility of the brain because of this acoustic window, and that is a marker of fetal craniosynostosis. The most relevant anatomic landmark of the brain is probably the anterior complex. That is the ensemble of cavum septoplucidum, the leaflets of the septoplucidum, the anterior horns, the corpus callosum, and the interhemispheric fissure. We should be able to identify the CSP between 17 weeks and late gestation. Non-visualization or abnormal appearance of CSP is a marker of pathology, mainly midline pathology. We can have a systematic evaluation of the brain around the CSP and the anterior complex. If we have a non-visualization of CSP and a wide separated anterior horns, we may suspect of complete agenesis of the corpus callosum. In this situation, we have absence of CSP and a wide interhemispheric fissures. It seems that we have too many lines. This is very characteristic of complete agenesis of the corpus callosum. In this situation, we should evaluate in mid-sagittal and coronal views to confirm the diagnosis. We can also have fused anterior horns. That should prompt the differential diagnosis between agenesis of CSP and lobar holoprosencephaly. In the first one, agenesis of cavum septoplucidum, we confirm that in coronal views that we don't have the leaflets of the septum, but we have a complete interhemispheric fissure. In mid-sagittal view, we have a completely normal corpus callosum. But we should have the differential diagnosis with lobar holoprosencephaly. In this situation, we have anterior fused horns, but in coronal view, we have an incomplete interhemispheric fissure diffuse frontal lobes. We also have the anterior cerebral artery running under the skull. A third situation where we are not able to identify the CSP, but the CSP is present, is obliterated CSP. It's normal in late gestation or is frequent, but it can occur also before late gestation. As in this situation, we are able to see the leaflets, but there are no fluid inside it. In coronal view, we are able to identify the two leaflets, but no fluid in it. And also in sagittal view, we are able to see a normal corpus callosum, but not without fluid on the cavum. But if isolated, is most probably a benign finding. Another situation is that we have a present CSP, but abnormal in shape, not rectangular, but squarish. And that is associated with degenesis of corpus callosum and also partial agenesis of corpus callosum. In this situation, we have a shorter and wider CSP. We can evaluate it in the subjectively fashion or use a CSP ratio that was published, and that was associated with partial agenesis of corpus callosum. So, a squarish CSP should trigger a neurosonography. As a key point, we must remember that CSP must be demonstrated on the three axial planes, and it should be longer than wider. The ventricular assessment also is included in screening. We should do it in the standard approach. The image should be properly zoomed, and in strict axial plane, you should place the focal zone at appropriate level We should have anatomic landmarks well visible, ambient system and CSP, and we should locate the parieto-occipital sulcus and place the calipers at this level in the inner to inner fashion. It's very difficult, or sometimes it is difficult to assess the proximal ventricle. We can overcome it by tilting the probe to the posterior area, and here we can have a slightly oblique plane and have a qualitative evaluation of it. We may be aware that we could overestimate if we measured in this plane. The posterior fossa is also included in the screening. We must utilize the mastoid fontanelle to have a clear access to it. In the cerebellum, we should study the contour and also the echogenicity. In this situation, we have a hyperechoic lesion of the cerebellum that is very characteristic of cerebellar hemorrhage. After a couple of weeks, this lesion will be absorbed, and we have a subtraction in the contour of the cerebellum. Another situation is when we have fused cerebellar hemisphere because we have absence of the vermis, the genesis of the vermis, and that is a rhomboencephalosynapsis. It's associated with a small DTC and frequently with supratentorial malformation. To have sure that we have the vermis, we have to identify the fourth ventricle, and the fourth ventricle should be wider than longer. If we had a fourth ventricle like this one, who is longer than wider, that should prompt a complete sagittal evaluation because it's a marker of vermian degenesis. We should measure the cisterna magna if it seems subjectively abnormal, but we must be aware that acoustic shadowing of the proximal bone may simulate enlarged cisterna magna. One may note that we have an interruption of the distal bone. If we tilt slightly the probe to the mastoid fontanelle, we will have a complete view of the cisterna magna and could place the measurement in this place. Obliterated cisterna magna and the banana sign is a typical aspect associated with open spina bifida. So in screening, we should have a longitudinal view of the fetal spine, assess the skin, and with tilt movements of the probe, we should go from one side to another and identify the conus medullaris that is a rule of thumb at the level of the kidneys. On axial view, we should locate the three ossification centers and sliding the probe, do a complete evaluation and confirm that the neural tube is closed. Cystic posterior fossa will be discussed by Professor Luke, and the Sylvian Fisher assessment by Professor Laurent Guibault, so I will skip this and go to proximal assessment of the brain. Sometimes it's difficult to assess the brain because of reverberation effects that obscure the proximal half of the brain. We can overcome it by tilting the probe posteriorly. We have a slight oblique plane, and we could assess the proximal and distal Sylvian fissure. Another way is tilting the probe to the baby's shoulder, and in this way we have a similar to a parasagittal plane where we can identify the symbol fissure, the posterior horn, the choroid plexus, and the parenchyma. In this case, we identified a posterior horn cyst, which is very characteristic of CMV infection. Another way to have a proximal assessment of the brain is just rotating the probe 90 degrees from an axial plane. In this way, we obtain an almost coronal plane, here through the anterior complex and here through the posterior horns. Moving to the sagittal evaluation. From axial view, I start locating the profile, then apply a gentle pressure, and in this way I will obtain a mid-sagittal view of the brain. So now my left hand will apply a gentle pressure. I return to the baby profile, and in this way I will obtain a mid-sagittal view. In this transabdominal mid-sagittal view, I can identify the CSP, the corpus callosum, the thalacroidea, the third ventricle, the interthalamic adhesion, the vermis, and also the fourth ventricle. Sometimes we need to have more detail on the rostrum and the splenium of the corpus callosum, and we can do it by moving the probe from the anterior fontanelle to the posterior fontanelle. And with this movement, we are able to see the splenium and the rostrum of the corpus callosum. If we move to posterior fontanella, we are able to obtain the mid-sagittal view of the posterior fossa. And here we can identify the brainstem, the vermis, now the vermis, the fourth ventricle, the vermis, the Sylvian aqueduct, the primary fissure which divides roughly the vermis in 1/3 superior and 2/3 inferiorly. To obtain the perisagittal plane, we should tilt the probe like we have done for the spine. So from the mid-sagittal plane, we tilt to one side, return to the mid-sagittal plane, and tilt to the other side. Here in the 3D reconstruction, to demonstrate how the plane is viewed, we can identify the caudate nucleus, the thalamus, the caudothalamic groove, and the choroid plexus that is typically posterior to the caudothalamic groove. Here we can also identify the contour of the ventricle wall and the convexity of the cortex. In this situation, we have a periventricular hyperechoic halo and posterior cysts, which are associated with CMV infection. And in these two situations, we have abnormal contour of the cortex, which are associated with cortical, malformation of cortical development. And here we have a hyperechoic ventricular wall, which is associated with intraventricular hemorrhagia. A more lateral perisagittal view allows us to evaluate the insula and the Sylvian fissure. Rotating the probe 90 degrees, and then with a combination of tilting and sliding, we will evaluate all the coronal planes. We describe 4 coronal planes, but the evaluation is a continuum between them. The first one, the transfrontal, will have an interhemispheric fissure and the sphenoid bone. The second one, the interhemispheric fissure, is interrupted by the corpus callosum, the genome, and the CSP. The third one, the transthalamic plane, we are able to identify the corpus callosum and the CSP, but also the Sylvian fissure. We can compare it with a normal sequence of Sylvian fissure, for instance, with this baby with 27 weeks. We can choose what is expected, and we can see that we have a quite abnormal Sylvian fissure. In this plane, we can also identify the thalami and the optic chiasma. The 3D allows us to have a correlation between 2 different planes. In this sagittal and coronal evaluation, you can see the optic chiasma in the 2 planes. And the last coronal plane is a transcerebellar one, where you can evaluate the occipital horns, the cerebellum, and the calcarine sulci after 26 weeks. And now it's time to release the pressure and finish our evaluation. So, screening is a qualitative and quantitative assessment of the fetal brain, which relies on axial planes, give us formal indication to neurosonography. We can add additional focus on sutures and fontanelles, improving our acoustic windows, have an evaluation of the CSP and the interior complex, have a standard approach of ventricular measurement, avoiding the overestimate of the atrium, have an evaluation of the fourth ventricle, a proximal evaluation, and also an evaluation of the sylvian operculization. Fetal neurosonography is a multiplanar evaluation with high-resolution probes. We can do it transvaginal or transabdominal. Personally, I always start with a transabdominal approach and then move to a transvaginal one. Doppler may be useful, but not very frequently. Assessment must be systematic. I think this is the key point. We have to have a notion of a complete evaluation and should be adjusted to gestational age. MRI can add information, but it is complementary to neurosonography. I would like to thank you your attention, and if you have any questions.
Thank you so much, Miguel, for this nice and very clear presentation. We leave the question for the end of the webinar. So I will introduce the next speaker with Professor Luc Ducat. Professor Luc Ducat is currently the director of the Fetal Maternal Medicine Department at the University Hospital of Louvre. And his main interests are in ultrasound training, fetal brain, and fetal therapy. And for this evening, Luc has chosen a very exciting title, a systematic approach to intracranial fluid field lesions. Such lesions are always a challenge to know if they are extraxial, intraxial, tumoral, ischemic. So Luc will give us very clear information about how to face such a lesion. Thank you, Luc.
Okay, thank you very much for this nice introduction, and thanks to Canon for allowing me to present today on a topic concerning the brain, which is a quite interesting field for ultrasonographers. So let's kick off immediately. And as Dr. Guibault already said, cysts appear quite often in the brain. When we define a cyst for ultrasound, it might be a little bit different from the definition from morphology or pathology, but for us, a cyst is a typically rounded or oval structure that does not contain any ultrasound information, so it's anechoic and has a smooth, thin wall and contains no other components usually or septations. And when you put on color flow, well, usually the color is absent, of course, and this is the typical consideration for a cystic structure. Now you can see later on in my talk that this might be, all these different types of aspects might be of interest in order to differentiate between various structures looking like a cyst in the brain. So as already mentioned, these are very relatively common entities compared to other ones in the brain with a wide etiological variety. And you can see in the table on the right-hand side the different etiologies related to that. Besides errors in embryonic development, we address these cysts also in conditions like tumors, infections, parasitic infections, or let's say in cases of inflammatory conditions. Although they are very common, the information on outcome, neurological development, is quite sparse and most of the time relies on case reports or series, and often also on postnatal diagnosed cases and looking back to the prenatal information that was available by ultrasound. Only in recent years, some larger studies and overviews have appeared concerning several different topics on cystic lesions in the brain. So if we look into the brain and try to classify these cystic lesions, then we try to figure out first what's happening supratentorially and next in the region below the tentorium. So in the supratentorial region, so the brain itself, we look at lesions associated with the intraventricular space, in those related to the brain parenchyma, and those related to the extra-axial space. And this makes already sense, of course, because now you can define different type of lesions and different type of pathologies related to the aspect of the brain where they are located. First of all, the intraventricular lesions. The king of the intraventricular lesions, of course, is the choroid plexus cyst. We know that they occur in about 3% of mid-trimester ultrasound scans, and they have a various appearance. They can be solitary, multiple, associated with the choroid plexus, of course. But as we speak, you have two examples. You can see that they are in the right-hand clip, different in size, different in numbers on both sides, but also they can fill completely the lateral ventricle and give the impression of having a ventriculomegaly. When we diagnose this, we have to be very careful because they are still a burden to the patients. Patients get anxious and might react quite strangely upon this rather benign condition. So we have to be very careful and explain to them that this is a reassuring finding in those cases that where there are no associated malformations present. And the addition of supranumerary malformations, of course, should lead to fetal karyotyping. This is another case where we are not reassured by the findings because this fetus does present other signs besides the choroid plexus cyst, like sandal gap, clenched hands with overriding fingers, abnormality in the posterior fossa with a very small vermis, and also an AVSD. And when we karyotype this fetus, of course, it's not surprising that this added up to trisomy 18. So we have to reassure the patients, of course, when we talk to them about this cystic structure. We also have to address the issue that they usually disappear completely by the end of the second trimester. But even if they do not disappear and they are isolated, they do not have any impact on neonatal outcome whatsoever, and therefore further follow-up should not be necessary in those isolated cases. Now, this is something that looks very similar to the choroid plexus cyst. It's called the cystic choroid plexus papilloma. Usually these papillomas are echogenic and are tissue-like structures, but in some occasions they do produce severely highly amounts of cerebrospinal fluid, and the tissue component is rather small, as in this case. They are benign tumors, and they are actually derived from the epithelial cells lining the ventricular choroid plexus. But they all are hypervascularized, and this is really of importance to the neurosurgeon after birth. Due to their production of cerebrospinal fluid, they rapidly devolve hydrocephaly, and this might also be due to the obstruction of flow of the cerebrospinal fluid to the third and the fourth ventricle. So these cases are benign, but usually occur late in gestation and do tend to grow rapidly due to the overproduction of cerebrospinal fluid and might result in hydrocephaly. Although the condition has a very good survival rate, patients need to deliver in a tertiary care center because of the importance of having a neurosurgeon that might operate on these children early in neonatal life. The only risk here is of severe hemorrhage, and the neurosurgeon, of course, is aware of this problem. Another benign condition, which occurs quite often in association with congenital infections, for instance, is an adhesion in the posterior wall of the lateral ventricle. Actually, this is not a typical cystic lesion in the brain. It's rather an adhesion. You can see on these occasion here the adhesion on the posterior wall, and on this other image as well. So this is a benign lesion if it's isolated, and it has been seen most often in cases with congenital infections and most likely in CMV-related infections. So therefore, if you can see it, it's usually in without any other associated malformations of CMV, a benign condition. But we have to look into these severe ultrasound brain abnormalities that are associated with congenital CMV infections and do tend to have a very bad prognostic outcome compared with the mild brain lesions and the additional extracerebral ultrasound abnormalities, where we do need more markers in order to predict severe neurological impairment. Finally, if you look into the ventricular system, there's also another cystic-like lesions, which appears as a rather heterogeneous, irregularly shaped formation, and this is a retracted clot. And of course, this relates to intraventricular bleedings that usually occur late in gestation, late second, early third trimester, and are often related to the fragility of the blood vessels at the germinative matrix. These lesions are classified in different types, from type 1 to type 4. Of course, both cases that you see here are type 3, extensive lesions with ventriculomegaly in association. And you can see in these lateral ventricles the formation of clots at different points. Also here, very heterogeneous lesion, but cystic components and echogenic spots. And this is, of course, related to the fact that intraventricular hemorrhage does present in different ways according to the delay after the intraventricular bleeding. So in phase 1, when the bleeding is fresh, it's like an homogeneous hyperechogenic area. But as time progresses, there is absorption of this clot and changing into more liquid type lesions. And finally, if we have time enough and wait long enough, this type of lesion might resolve spontaneously with complete resolution and only recognizable by, for instance, a fetal MRI that picks up the hemosiderin layer in the lateral ventricle. So here, of course, this counseling is more complex and relates actually to the fact that we have to look into multiple causes that may be related to this intrauterine ventricular bleeding. Look at platal disorders, look at certain genetic defects that may cause this condition, because not for the present gestation, of course, but mainly for the future. There might be some treatment possible to prevent these intraventricular bleeding in cases of alloimmunothrombocytopenia, for instance. Now let's look into the brain parenchyma. And the first lesion we will discuss is or the pseudocyst or the frontal horn cyst. They are closely related to the ventricular wall. They often are present on two sides bilaterally, and most often at the frontal horns. They are also named differently according to the paper that you will read, as periventricular pseudocyst or cortical cyst, frontal horn cyst, subependymal cyst, and so on. They occur quite frequently, and for neonates at the intensive care unit, if you do ultrasound scans, they may appear up to 3% of the cases. And their pathological origin is mostly related to small type 1 bleedings, but also congenital infection is often the case, germinal lesions, and some rare metabolic conditions may also related to these frontal horn cysts. Now, it's very important to differentiate this cyst from another type of lesion that is usually very close by, and this is periventricular leukomalacia. And as you can see on the bottom right of the screen, this image by Gustavo Malinger shows you how you can differentiate on a coronal section by drawing a line that connects the tip of the anterior horn of the lateral ventricle to the cortex, and the cystic lesions that appear below this imaginary line are called frontal horn cysts, where those that appear above are periventricular leukomalacia lesions. There have been quite a lot of papers out there concerning small series, and this is a bigger, more recent paper showing you the importance of the periventricular pseudocyst in relationship to their prognostic factors. And as you can see here, the majority of cases appears bilaterally at the frontal horns, so that leaves about 1 out of 5 for the temporal horns, and they usually tend to be very small, below 10 millimeters. In 60% of the cases, they are isolated, which is a good finding because their outcome is excellent at that time. But in some cases, at about 1 out of 3, there are additional CNS malformations, and sometimes MRI might be beneficial to see or spot these very mild lesions. So what can we miss by ultrasound, for instance? And this is addressed in this paper. You can see here the list of additional findings, usually ventriculomegaly, vermin hypoplasia, sometimes corpus callosum agenesis or dysgenesis, and malformations of cortical development. What this paper also addresses is the lack of abnormal genetic findings in this pathology, which is very important because previous papers have addressed this issue and attributed a higher incidence of chromosomal abnormalities to periventricular pseudocysts. You see here the second slide shows you the outcome. The majority of cases have a normal development and, of course, live birth. But those cases that end in a termination of pregnancy are usually those cases that have additional CNS malformations that also were confirmed on pathological examination of the fetus afterwards. This is such a condition where the frontal horn cyst is associated with additional findings, and you can see on the parasagittal image of the lateral ventricle that the small arrows show you the irregular lining of the lateral ventricle with a huge indentation in the ventricular wall, most likely related to migrational disorders and a worse neurological outcome. So if these cysts are isolated and small, they usually have a good outcome, but be aware of the fact that small lesions, brain lesions, might be associated, and therefore MRI might be beneficial in order to get a better view on the prognosis. So we already addressed leukomalacia, especially where we have to find it in the drawing, comparable to the previous slides. You can see it's above this imaginary line. And this is usually a destructive lesion, of course, related to an hypoxic or ischemic insult closely to the ventricular wall, and this relates to a bad prognosis. So it is important to differentiate both types of lesions because they are lined quite closely to each other on the anterior walls of the lateral ventricle. Dr. Branco already addressed this issue. I quickly go into that because he told that this indeed lesions associated with CMV, so the periventricular cystic white matter lesions occur typically at the border of the lateral ventricle posteriorly, but also at the lateral part of the lateral ventricle. And usually these cysts lay in an echogenic lining of the lateral ventricle, mainly related to inflammatory or inflammation of the periventricular wall. You can see images on the parasagittal view, on an axial view posteriorly, and then in the last slide you can see a large one associated with the posterior effect, also with a small brain hemisphere, a large subarachnoid space, and cortical malformation in this case with a severe CMV infection. So in this case, when you encounter this type of lesion, it would be wise to perform an amniocentesis and look for a PCR for CMV and confirm the lesions with a fetal MRI in order to counsel the patient correctly about the prognosis. So here, once again, this table shows you now that these periventricular lesions are in the group of the severe ultrasound brain abnormalities with a rather infauste prognosis, so bad neurological outcome. Now, sometimes these cystic-like structures in the are in connection with the lateral ventricle, but actually parenchymatous lesions that herniate into this ventricular system, also related most likely to hypoperfusion in second trimester fetuses, resulting in liquefaction of the brain at that region and resorption of the destroyed brain tissue. And as you can see in these two examples, on the left side, you have two very large porencephalic cystic lesions in relationship with the lateral ventricles. And then on the clip on the right-hand side, you can see on a coronal image two porencephalic cysts, one on each side, very irregularly shaped in communication with the ventricle itself, and here due to an hemorrhagic insult in the brain. So the prognosis here is, of course, rather bad because it's associated with neurological impairment in terms of hemiparesis, developing of seizures, and severe neurodevelopmental delay. You might be able to look in some of these etiological factors. They tend to be, or they have some of the same causes as intraventricular hemorrhage, but as for the same reason as for intraventricular hemorrhage, the investigation usually fails to demonstrate any particular etiology. Now, moving to the extraaxial space. This is a space that actually is formed by the arachnoidea, and this arachnoidea is derived from vacuolization of the dura mater and splitting it up into the pia mater, dura mater, and then the space in between. And this is prone to formation of cysts. They can appear as single or multiple cysts, as you can see here in this drawing, where you can see that these actually appear on the surface of the brain at the level of the main fissures, or also in between the brain hemispheres, deep in the brain above the sella turcica. So they are located between the dura and the cortex without communication with the arachnoid space. And if you investigate the fluid of these cystic-like structures, you might see that this fluid is not exactly the same content as the cerebrospinal fluid. These lesions tend to be isolated in most of the cases, but previous publications also have shown that sometimes there are mild neurological malformations or discrete neurological malformations in terms of nodal heterotopia. So it's very wise to consider, in this case, the performance of fetal MRI in order to rule out additional brain lesions. They do tend to disappear spontaneously sometimes because of spontaneous rupture, and then of course the problem is resolved. But quite often they do not resolve spontaneously, and they have to be looked after after birth. This case on top here shows you 5 arachnoid cysts at the base of the skull in this fetus, and this fetus had a good prognostic outcome because some of these cysts disappeared completely, and the other ones did not need any attention after birth because there was no compression of surrounding brain tissue. This is an interhemispheric form, compressing the lateral ventricle anteriorly, but without formation of hydrocephaly. And this is a midline cystic arachnoid cyst compressing the mid portion of the brain, but without additional involvement. Now, some of these cases do tend to have a mass effect, and when, of course, the structures below this arachnoid cyst are of major importance, then this might result in additional problems like, for instance, compression of the chiasma opticum and therefore visual impairment, or compression of the pituitary gland and therefore endocrinological signs that might be addressed after birth. So usually they do not need much of attention. Sometimes postnatal endoscopic decompression by fenestration into the arachnoid space is necessary, but then of course the problem is solved. So the outcome is most of the time favorable. Second cyst is also very benign, is at a interhemispheric region and is called the cavum interpositum cyst. It's a median structure. It actually pops from below from below the splenium of the corpus callosum, as you can see in the sagittal image on top. And this also is a very benign condition. In the axial plane, you can see the interhemispheric position, more posterior behind the cavum septum pellucidum. Here in this case associated with a mild ventricular megaly, but usually these cysts tend to be without additional malformations. Since we have a program on meningomyelocele in our hospital, we evaluate these fetuses with spina bifida very much in detail, and we now appreciate that quite often these cases do tend to have this type of cystic lesions in association with the disfiguration of the corpus callosum. Outcome for these cases is only in small series, but as these small series show no additional side effects and no additional developmental delay, we can classify this cyst as being benign. This also has been addressed by Dr. Branco and the corpus callosum agenesis, where the absence of the cavum septum pellucidum and the colpocephaly with teardrop-shaped ventricles are pathognomonic for this condition, but sometimes also the left ventricle is dilated and more cranially, and this is one of the additional landmarks that you might look for in corpus callosum agenesis. On top, you can see here a very small dilated cystic structure here, also rather small. See the separation of the hemisphere at the midline and no communication in between them, suggesting complete agenesis. And this is a very severe case of interhemispheric cystic formation in association with complete agenesis of the corpus callosum. And this had a bad outcome because on MRI there were also associated brain lesions. So here the outcome, of course, is depending rather on the associated findings associated with corpus callosum agenesis. And in those cases where the corpus callosum agenesis is isolated without additional structural defects in the brain, the neurodevelopmental outcome might be quite well, but we still have to consider that in about 10 to 15% of the cases, there are more moderate to severe disabilities present in those cases. Okay, moving on to those lesions that are actually not really cystic lesions, but do appear as a cyst on a 2D ultrasound scan. And these are the vascular anomalies. And one of the most typical ones is the AV malformation of the vein of Galen, which occurs in the center of the brain. You can see the examples here on top. This is typical AV malformation with a whirlpool effect of colors, looking into the feeding vessels, and of course it drains through the sinus rectus to the confluence of the sinuses. Okay, so in 2D it looks like a cystic structure, but with color you easily can recognize, of course, the AV malformation. This is a more atypical AV malformation. You can see here the cystic-like structure now on a coronal image, but not in the center, but very lateral in the image. And also by putting on color Doppler, you can see the huge blood flow with drainage towards the confluence of the sinuses and dilatation of that confluence as well. Prognosis of these conditions is very variable, as you can see that that occurs despite embolization or because embolization in nearly half of the cases. And this is in the great center of Paris where they have the largest experience. But if the embolization turns out to be quite successful, then in general, neurological outcome might be fairly good. This outcome is also related to the additional findings on brain MRI, where you can find additional cortical malformations related to the high blood flow in the region of this AV malformation, and sometimes even bony defects related to this high blood flux. Finally, for the supratentorial lesions, you can also have durosinus AV malformations. And here I have two examples of these cases here. This is what we usually tend to call thrombosis of the torcular hierophili, where you have a huge distended dural sinus here, and in this dural sinus at the back, you have an echogenic structure, which is like a clot. This baby did quite well afterwards, because at 35 weeks, this zone decreased in size tremendously, and we could even not recognize the condition after birth. So this baby did very well in terms of neurological development as well. This case is, sorry about that. This case is a more active lesion with also an AV malformation in relationship to the dural sinus, which is very active. This baby did rather poorly, because it needed at least 4 embolizations before this lesion stopped, and had some neurological impairment afterwards in relationship to this treatment of this huge condition. There are even more rare conditions, of course. I just give you one example that puzzled me for quite a while, and this is a chorionic fissure cystic structure on both sides, whereas the chorioid plexus is not contained completely into the lateral ventricle, and the cystic structure on the chorioid plexus appears actually in the extraaxial space. Now, this is all supratentorial. Now let's quickly move into the region of the below the tentorial, and of course then we have to look into the posterior fossa cysts. And Dr. Branco addressed already very beautifully how you can manage to visualize this posterior fossa properly by looking not only in an axial plane but also in a sagittal plane, in order to be able to distinguish the vermis and to characterize the vermis and the structures laying underneath. On the axial plane, you have to be careful not to angulate the probe too steeply, because then you might overestimate the cisterna magna and create a pseudo-megacisterna, or also create the impression of a vermin hypoplasia, because you have the impression of a keyhole in the posterior fossa. There's also a rule that the evaluation of the vermis needs to be done after 20 weeks of gestation, because of complete formation of this structure, and therefore diagnosis of vermin hypoplasia might be very tricky in earlier gestational ages. So this is an image I will not discuss, because it has been beautifully illustrated previously. What we did learn from the previous years is that when you use 3D ultrasound, it's more often you are more often able to construct this image in sagittal plane for the vermis and identify the different structure than you can do by 2D ultrasound. And MRI, of course, is still better than all the other two investigations. How big is the vermis? Well, a rule of thumb, as you can see here on the right-hand side, at 20 weeks is about 10 millimeters, 25 weeks about 15 millimeters, and at 30 weeks about 20 millimeters. So this might guide you a little bit when you look into the matter. So look now into the different entities. Let's move from megacisterna magna over Blake-Boyd cyst to vermin hypoplasia and then the Walker malformation. So why do we tend to focus on these lesions? Because not all of these conditions do have a good outcome, and this was what is expressed in this slide, where you can see that the Dandy-Walker malformation in the blue bars shows you a huge number of additional malformations on MRI, but also on ultrasound, of course. Also in postnatal diagnosis, there are quite a lot of additional malformations present that we did not appreciate on prenatal ultrasound. And of course, the outcome in those cases tends to be fairly poor, whereas for the other conditions, as you can see, the associated chromosomal abnormalities or additional malformations tend to be rather low. So that's why we have to differentiate, especially between Dandy Walker and all the rest. So this is an example of a megacisterna magna, defined as a larger diameter of the cisterna magna of more than 10 millimeters on an actual plane. And in order to differentiate between other cystic lesions in the posterior fossa, it's very important you can construct a parasagittal or sagittal image of the vermis, allowing you to measure that vermis correctly and address the position of the vermis, which is now, in this case, normal. It lays under the medulla oblongata, and you have a normal formation of the fasciculum, triangular shaped, and there's actually no other malformation present in the posterior fossa. So this is most likely an isolated megacisterna magna. And of course, you have to look for other brain anomalies in this case, but usually has a good prognosis. As you can see here, most of the cases are isolated. They can regress in utero spontaneously, if they are associated with additional malformation, then the prognosis is, of course, not so good as it should be. Then 1 out of 4 has an abnormal neurological outcome. In the table below, you can see that this abnormal outcome in megacisterna magna in nearly 13% of the cases, and this relates usually to abnormal language development and communication skills and reduced visual-spatial perception. So here, MRI might be useful in order to look into the other, perhaps minor malformations associated with this condition, and in most of the cases, the neurodevelopment outcome tends to be fairly good. Moving to Blake-Boyce cyst, as you can see here in this condition, on top, the clip shows you that there is like a cleft-like situation where both hemispheres of the cerebellum are split, as in a keyhole sign. It's difficult to appreciate the size of the vermis on this image, and therefore you have to address this in a sagittal plane, where you can see now that the vermis looks completely normally formed with a normal pointed fasciculum, but the vermis is elevated from the underlying structures in a small angle, and this angle allows you to differentiate also between the different types of posterior fossa cysts, as I will show you in my last slide. 3D rendering, once again, is very helpful as it illustrates very clearly the size, the position of the fasciculum, and the upward rotation of the vermis from the medulla oblongata. So here there is a risk of, or a small risk at least, of associated malformations in the brain or extra CNS malformations, very rarely chromosomal abnormalities. Sometimes they do disappear in utero very late, and that's why the diagnosis is not always confirmed after birth, but only in the minority of cases this disappears. The neurological development seems to be okay. Vermin hypoplasia is rather difficult to diagnose. This also has like a cleft-like appearance of the posterior fossa with a cystic-like structure in between the cerebellar hemispheres. And now the parasagittal or sagittal image allows you to detect a smaller part of the vermis. Usually it's the inferior part that disappears, so you have a displacement actually, or pseudo displacement of the primary fissure. There's also an abnormality of the fasciculum, which is not pointed anymore, and there is an angle between the medulla oblongata and the vermis that is increasingly higher than that in Blake-Boyce cyst. Now, in those cases, there are associated malformations in the brain more often, and also extra CNS malformations present. Also, confirmation after birth is not 100%, but some of the time these are overdiagnosed, especially in very early cases, and very rarely they are associated with chromosomal abnormalities. So in these cases, in our center at least, we perform MRI in order to look for other associated conditions in the brain. And we do not know exactly what their outcome is in those cases that this lesion tends to be isolated. We probably have a fairly good outcome, but from the time that there are additional malformations in the brain, the outcome might be very bad. And often these lesions in the brain might be very subtle, and that's why the outcome might be actually worse than expected just by imaging this condition. Finally, we arrive at the Dandy Walker malformation, and here the typical key points are dilatation of the cisterna magna, of course, with cystic formation in between the cerebral hemispheres. Apparently no presence of the vermis, but as said, difficult to assess in an actual plane. If you look on the actual on the parasagittal plane, then you can appreciate that there's a very small to almost inexisting vermis present, and there is an upward rotation of the torcular, which is of very high diagnostic importance in this condition. So the scheme already shows you hypoplastic to nearly absent vermis, but it's not always the case in Dandy Walker malformation, and steep angulation of this vermis remnant, so very huge angle between the vermis and the medulla oblongata. Sometimes these lesions are associated with minor brain malformations. This is a small meningocele rupturing through the occipital bones, but on other occasions, associated malformations in the brain are present in quite a high number of cases, and also extra CNS malformations. Hydrocephaly develops in quite a substantial amount of cases, and chromosomal defects have to be ruled out as well. Additional malformations are missed also quite often, and that's why prognosis in this condition might be very poor, with an abnormal neurodevelopmental delay in about 60% of the cases, and motor delay in 30% of the cases. So here you can see the, this is my final slide, shows you that you might get some help from the brainstem vermis and the brainstem tentorial angles to allow you to differentiate between the different lesions, in addition to the measurement of the size of the vermis. And you can see with increasing, let's say, severity of the malformation, the angles increase as well. But sometimes benign conditions like Blake-Poich cysts might be very, very huge, and therefore also elevated tentorium, and the differential diagnosis might be very difficult because structures get compressed at that time. So this is the summary of the outcome of the posterior fossa cyst as it has been published in this systematic review. And we have actually to keep in mind that Dandy Walker malformation is very often associated with aneuploidy and a bad neurological outcome and motor delay, whereas for vermin hypoplasia and Blake-Poich cysts, the outcome usually tends to be fairly good. But for vermin hypoplasia, we actually do not know exactly always what the brain tells us, and what we do have to expect, even if our ultrasound and MRI images do not show major malformations. So I hope I got you through a more systematic approach of the intracranial fluid-filled lesions. And of course, any questions from you are welcome. Thank you so much.
Thank you so much, Luc, for this very complete and didactic presentation of the cysts of the brain. For sure, the audience will have many questions at the end of this webinar. So just to be in time, I will switch to my presentation about spindle imaging of the fetal cortex. From normal to pathology. As an introduction, I will say, what are the reasons to look at the fetal cortex. In fact, all depends on the context. In a low-risk population, I mean basic sonographic exam, analysis of the fetal fissure can be or should be integrated to the basic sonographic exam as the main marker of the supratentorial maturation. On the other hand, in fetal medicine, analysis of the fetal cortex is important using either neurosonogram or fetal MR. Indeed, when facing a non-specific cerebral feature such as isolated ventriculomegaly or decreased encephalic biometry, analysis of the fetal cortex is an important tool for the etiological approach of the findings and to look for any underlying pathology. In a classic context, such as when facing CMV infection or situation at risk of vascular compromise, one should look for cortical insult, especially polymicrogyria. Looking at the fetal cortex is also important in assessing the postnatal outcome for some CNS malformation, especially in case of agenesis of the corpus callosum or cystic malformation of the posterior fossa. And finally, when facing index case of cortical malformation, analysis of the fetal cortex is crucial to look for any recurrence, especially in the absence of any mutation found. Whatever the context, in fact, a systematic analysis of the fetal fissure is required. And one should note that the posterior margin is the main marker of gyration of the supratentorial maturation, while the anterior margin is more the reflex of the cerebral volume. To do so, we should perform an axial reference plane. And regarding the reference, one should note that the anterior landmarks should be the fordex colon and for the posterior landmarks, it should be the V shape of the ambient cisterna. We have recently stressed with Edwin Corello the importance of using these precise landmarks, since the shape of the fetal fissure may change if the landmarks are not identified accurately, as you can note in this illustration. This is here the fordex colon, and you see this is 26. If you move to here the CSP at different level, the shape of the fetal fissure may change, and this is more 24, but this patient was at 26. So this is very important to look and to take as anterior landmark the fordex colon. So one should know for sure the shape of the fetal fissure according to gestational age. You know that at 20 weeks, the insular and the temporal lobe make an open angle. And this angle will be 90 degrees at 24 weeks. Afterwards, the temporal lobe will cover progressively the posterior part of the insula. It will be covered completely at 32, all the way at 28, and a quarter of the way at 26. And we can discriminate 26 and 28 by this sulcus, the superior temporal sulcus, which appear around 27. So now we have speak about normal. Let's speak about pathologies. And these pathologies can be either diffuse or focal, and we'll begin with diffuse anomalies. These anomalies can be divided according to the different stages of the formation of the cortex, going from anomalies of the proliferations, leading to simplified cortex, anomalies of the migration, leading to lysoencephaly type 1, and finally, polymicrogyria, which are related to anomalies of the corticogenesis, which can be related to vascular insult, infection, or genesis causes. One should note that in case of polymicrogyria, the imaging pattern can go from excessive gyration to smooth cortex. But in all cases, in all these conditions, the Sylvan fissure is abnormal, and one should note that it's in fact not the ribbon with ultrasound which is abnormal, but the surface. As illustrated in this case, it's a first trimester CMV infection. One should note in this examination performed at 23 that there is a decreased cephalic biometry associated with enlarged hair peripheral faces, suggestive of classic event. But also, you can see that there is an undulating cortical pattern of the cortex, suggestive of excessive gyration due to polymicrogyria. And here, what you see is the surface. It's the interface between the peripheral faces and the parenchyma. It's the surface of the cortex and not the cortex itself. If we move to these patients at 20 weeks, in which the cephalic biometry is increased, there is also an abnormal fissure compared to the control at 28, but also the surface itself is a little bit bumpy, and with MR, you see that here, for sure, there is a bumpy appearance suggestive of polymicrogyria. But in that case, what you see is not only the surface, it's the ribbon itself. And this is very important. And in that case, with megalencephaly, we did, in fact, exome, and we found, in that case, a constitutional mutation of AKT3. One should note that these three entities, simplified cortex, lesioncephaly, and polymicrogyria, are related to different genes. But all these entities can lead to a similar sonographic aspect, characterized by the smooth cortical surface on ultrasound. So you should not assume that a smooth cortex using ultrasound is equivalent to lesioncephaly at histology. And when you have a cortex, you should go to MRI to look for the cortical ribbon itself, its thickness, and the white matter. And you have to look for abnormal migration in the white matter, suggestive of migration anomaly. This is well illustrated in these cases. 3 cases, all these patients were referred for microcephaly at 28 weeks of gestation. And they showed the same sonographic aspect, a very shallow Sylvan fissure. If we look at all these aspects with ultrasound, it looks the same. But let's go to MR. For the first one, this is the MR. And in that case, you see that there is a laminar aspect suggestive of migration disorders. And this is lesioncephaly type 1. For the second one, almost the same aspect. Go to MR. In that case, you see the bumpy appearance. And this is not migration anomalies. There is no migration anomalies, but anomalies of the corticogenesis. And it was a polymicrogyria. And for the third one, if you do an MR, you see that there is no migration anomalies. And the cortex is smooth. There is no polymicrogyria. And this is due to abnormal proliferations of the precursor cells associated with microcephaly. And this is to have the MR after birth, a simplified cortex. So this is a very important issue. All these malformations are different entities related to different genes. And for genetic counseling, this point is definitely crucial if you diagnose lesioncephaly in all the three cases without any MR, and especially if the patients or the parents refuse any pathological examination. Because all these cases are different, but the same using ultrasound. We speak about lysanthropy type 1. That means there is a lysanthropy type 2. This is illustrated in this case. We are at 26. Look at the control at 26. There is no Sylvian fissure at all. There is ventriculomegaly. And there is also a ecogenic band at the outer surface of the cortex with no pericyspecific seen. This is demo. The pericyspal space has disappeared. And why? Because of this ecogenic band. This ecogenic band represents this band on pathology, which has extracortical neuroglial layer. That means there is over-migration which go, in fact, in the pericerebral spaces. In that case, in most cases, if you look at the posterior fossa, you will find a Z-shaped appearance of the brainstem with the abnormal migration here, the over-migration, the ecogenic band. And this is lysanthropy type 1, or cobblestone lysanthropy, which is related to Walker-Warburg syndrome. Let's go to focal anomalies. These focal anomalies are suggestive of classic insult. It can be related to infection, mainly CMV, and in that case, there is often patchy pattern. It can be related to focal ischemia, and it can be difficult to diagnose with ultrasound because they may be located on blind zone, especially on the proximal hemispheres. We can do oblique, as Miguel showed, but it can be tricky. And they are tricky when they are associated with a normal Sylvian fissure. Some features can be helpful and can suggest underlying clastic insult. Parenchyma anomalies, such as abnormal echogenicity, cysts, and Luke speak about cysts related to clastic events, calcification, and cleft. And there may be focal enlargements of the posterior of the pericyspal spaces with focal rupture of the CSP. Look at this patient. This patient was referred for arachnoid cyst of the ambient cisterna. This is for sure something wrong. It's anechoic. It can be an arachnoid cyst. But if you look closely, there is echogenicity of the parenchyma here compared to the other side. And there is some cystic lesions here. This looks not like an arachnoid cyst, but look like a plastic lesions. And if you look at the MR, there is for sure a porencephalic cyst here, expanding in the extraaxial space. And with MR, we show also that there is here a polymicrogyria, which was not seen with ultrasound for sure. Sometimes you can have some clue like this, some cleft. This is an open schizencephaly. A closed lip and this closed lip schizencephaly, which can be tricky to diagnose. But in this case, you see that there is no symptom at all. And when there is no symptom, you have to look for plastic events like this, plastic lysanthropy. This is a case which is really tricky because the ultrasound was completely normal. It was the follow-up of a surviving twin in a monochorial pregnancy. And in that case, with MR, you can see that there is focal enlargement here facing the parietal lobe. Using coronal plane, you can see clearly that there is symmetric loss of volume here related to a clastic event. And look at this and look at this. So when you are in the blind zone like this, it can be tricky to diagnose such a clastic event. So that means that after some issues related to monochorial pregnancy, MR is mandatory. So let's speak now about bilateral perisylvian cortical anomalies. These anomalies are related when there is polymicrogyria, often because of genetic origin. With this genetic origin, the polymicrogyria is very symmetric and can extend sometime in other areas. This patient was referred for ecogenic kinase, but there is not only ecogenic kinase. There is also some anomalies at the epiphysis, where there is some calcification, so it's suggestive of chondrodysplasia punctata. And looking at the MR, there is polymicrogyria on both sides, facing the fissure and extending in the frontal lobe. And this was a Zellweger syndrome, a metabolic disorder related to peroxisable anomalies. So think about genetic origin of polymicrogyria when you have bilateral perisylvian anomalies. But to finish with, I want to underline that these perisylvian anomalies can be encountered in many cases without any histological anomalies of the cortical contact, ribbon. It can be encountered in severe microcephaly, in neurological defect, but also in many anomalies of the cerebral organization. We have published in 2008 this article about the significance of abnormal Sylvian fissure. And one of the patterns which is abnormal is the lack of the anterior operculation in severe microcephaly, which reflects, in fact, the hypoplasia of the frontal lobe, in that case, at 28 weeks of gestation. Look here, you have a nice anterior operculation, and here, complete absence of the anterior operculation. So the anterior margin of the Sylvian fissure is a good reflex of the underlying cerebral volume, especially the frontal lobe. These patients were referred for abnormal operculation. And for sure, at 36 weeks, the Sylvian fissure is widely open. There is also some cysts here, and look at the biometry. It's very increased. And we did the MR, and you can see that the pericerebral spaces are very enlarged, and you see the cyst here and the open Sylvian fissure. These findings were confirmed after birth, as you can see, and this is clearly a very typical phenotype of aciduria glutaria type 1, macrocephaly with enlarged pericerebral spaces, with a widely open Sylvian fissure, with a normal cortex appearance, and this is really a diagnosis that you can make on the basis of prenatal imaging. And in that case, there is no index case because it's a recessive autonomic disorder. So for sure, when there is an index case, it's easier, but in that case, the diagnosis was made without any index case. Maybe this abnormal Sylvian fissure is familiar for you. Look, it's an old case, so the quality is not optimal. If you look here at the MR, you see there is also a sort of absence or a very not open Sylvian fissure, and this aspect, in fact, is associated with neural tube defect. And these gyration anomalies related to neural tube defects without any histological anomalies were called polygyria or stenogyra. And now we know that neural tube defect is a larger anomalies of the cerebral organization. The corpus callosum itself can be, in fact, digenetic, and there can be some cortical anomalies, such as this kind of anomalies. Abnormal operculation can be a clue to diagnose syndromic entities. And this abnormal operculation can be as specific as in this case, this patient was referred at 26 weeks for abnormal operculation. If you compare to the normal, the operculation is completely abnormal. There is a lack of operculation on the anterior margin, but there is no decrease in cephalic biometry. If you look at the MR, we are at 26. There is often a laminar aspect till 26. So this was not, in fact, a pathologic finding. The cortex is of normal thickness. And with this case, there is also some other features. There is a small vermis, hyperplasia of the vermis, and also hallus duplication. So facing these cases, these anomalies, in fact, at the beginning, it was the Sidon Fisher. We did a CGH, and we found a 16p microdeletion, which is a Rubinstein-Tebby syndrome. And in that case, you see that all begin with an abnormal Sidon Fisher. So the take-home messages about prenatal imaging of the fetal cortex is that you have different types of cortical anomalies. There are diffuse type and focal type. These focal types are most often related to ischemic events. For the diffuse type, you have simplified gyral pattern, encephalies, polymicrogyria of different etiologies, and all these entities are related to different genes and mutations. And you have also anomalies without any histological cortical anomalies, especially involving the Sidon Fisher. For basic ultrasound and third-level neurosonogram, you should look at the Sidon Fisher on an adequate axial plane, and you should be aware of the shape of the Sidon Fisher according to gestal age, and you should be aware also that this shape will change if you don't use the correct landmarks. You should know also that ultrasound is limited for the analysis of the whole cortex, and the ultrasound will give you information on the surface of the cortex and not of the ribbon itself. It's a major interest of the fetal MR, analysis of the whole cortex to the cortical ribbon, and also to the underlying white matter. And MR analysis is crucial in diffuse cortical anomalies to guide the genetic workup, especially if neuropathological examination is not available or not informative. So I thank you, Canon Medical System, to give us this opportunity to lecture. I had the opportunity to give a masterclass in Lyon in September 2020, but because of the COVID, it was cancelled. So I hope to see you in Lyon in a very short time when the COVID period will be over to do this masterclass with Canon. For Miguel, there is plenty of questions regarding the CSP. What do you do with a very small CSP? Is there some norms for the CSP? What do you do if the CSP is enlarged? So can you give some answer to this question?
Yes, for the measure, we already answered in the written. So we could expect from 2 to 9 millimeters. It depends on the gestational age, but it should be around that, 5 millimeters plus or minus 1.7 millimeters. And for the small septation, I think there is more frequently now with high resolution probes to see small thin septations inside the CSP, and I consider it is a normal finding. Very thin septation inside the CSP. And the other question was
maybe
in a
you have
large CSP on the third trimester. The Professor Luke already answered it. It probably should be a patent cavum verga, and is also a normal variant.
When the CSP is enlarged, what do you do? Because I've published that when it's very large, it can be a clue to diagnose 22q deletion. So you have to look at the thymus to look carefully at the heart.
Thymus and the heart, but if otherwise normal, I don't consider it indication for study the George deletion.
Okay. Look, regarding arachnoid cyst, do you think that MR is mandatory in arachnoid cyst or very large arachnoid cyst? Because we had two cases when it was said that it was an arachnoid cyst, and in one case it was an expanding parencephalic cyst, very large, and the other case, it's not very frequent, it was a large cyst, which was in fact a large mixed teratoma with some very cystic component and a very thin solid component. And with ultrasound, it was a little bit tricky. With MR, it was easier to do the good diagnosis.
I guess you're completely right. I guess actually at this stage, more often MRI is used to differentiate from different types of lesions. And if neurosonography is not completely satisfying by transvaginal scan and the approach of different planes, I would definitely urge to do an MRI examination, especially also for larger cysts, because there might be a compression factor. For instance, in those cases where the cyst is in the midline and compressing the chiasma opticum and the pituitary gland, it might be very beneficial to have an idea of this compression. But as you suggested, sometimes we think it's an arachnoid cyst, a simple arachnoid cyst, and it may hide a completely different diagnosis. So therefore, in most of these cases, we do perform associated MRI investigation.
Okay. So, Miguel, what are the significance of increased pericerebral spaces? It was a question.
Well, if otherwise normal, probably we won't valorize these findings if we have a normal neurosonography.
I think that when there is increased pericerebral spaces, one should look at two important features. Is there a ventriculomegaly or not? If there is ventriculomegaly with increased pericerebral space, look at the biometry. It's the biometry is decreased. That means it's a suspicion of microcephaly. If there is microcephaly with increased pericerebral spaces, that means that there is loss of volume of the parenchyma itself. So that means that there is atrophia of the brain. So this increased pericerebral space should be related to the cephalic biometry. If the cephalic biometry is increased and you have increased pericerebral space, what you have to look for is the head of the parents, because you can have benign macrocephaly with a large, in fact, pericerebral space with increased cephalic biometry and with, in fact, a sort of parents. It's not an anomaly; it's a marker of the family. Luke, do you have any question or remark?
No, I already answered a few of them during the session. So far, I do not see any additional questions to answer.
There is a question about for Miguel. Is it possible to see the pituitary gland and see the hypothalamus using ultrasound?
I don't think that we can see pituitary gland, but we can see the pituitary stalk. Yes, with a slight angle to the optic nerves. But I don't see that it is clinical useful. It's only a curiosity.
Yes, it can be sometimes useful to see the pituitary gland using MR when there is absence of the CSP. If there is absence of the CSP, in 90% of cases, it's variant of normal. But you know that it can be a syndrome.
Septo-aortic dysplasia.
Thank you for.
Yes.
And in that case, you can have some interruption of the stroke of, and in that case, the neurohypophysis is ectopic, and you can see this ectopy using MR. So in the workup of absence of CSP, looking at the pituitary gland can be useful, but it's very specific conditions, in fact.
Yes. And even a postnatal MRI normal do not exclude septo-aortic dysplasia.
There is a question about the best plan for diagnosing polymicrogyria. You can begin the answer, Miguel, and I will add something if you want.
I don't know. I will say that we probably should base the cortical maturation on ultrasound on the sylvian fissure and the global assessment of the other sulci. And if don't have any major alteration of the sylvian fissure and other sulci, we will miss it on ultrasound and we'll need MRI to diagnose it.
For me, it depends on which type of polymicrogyria you are dealing with. If you are dealing with genetic or CMV polymicrogyria, most of the time you will add the diagnosis of abnormality of the cortex using ultrasound. As I tell you, there is...
It's not isolated, yes.
But if you are looking at polymicrogyria related to a focal insult, in that case, because there is blind areas on the brain using ultrasound, and I show you a case with polymicrogyria very high on the cortex, and in that case, the sylvian fissure itself was normal. So if you are in a condition where you suspect polymicrogyria because you are in a condition where there is a risk of vascular compromise, when you are dealing with CMV infection, I think that MR can be mandatory. Even I trust most of the time more on my ultrasound exam. But in some cases, I will not do MR for all cases. But if I don't see any anomaly of the sylvian fissure, and I am in a situation at risk of focal polymicrogyria related to ischemia, I will do an MR. Any tips to diagnose Joubert syndrome?
I would suggest by ultrasound it's rather difficult, although we rely on this molar tooth sign, but it's usually very hard to diagnose, in my opinion at least. So I would say if there is suspicion of a small cerebellum and you cannot actually put a finger on it, I would say try to do an MRI in these conditions, because I think posterior fossa are very tricky, and I would not only rely on ultrasound in this case.
for sure, in that case, if you are in a situation at risk of Joubert, that means if you have index case, it's easier. In that case, you should have a look at the fourth ventricle, because the molar tooth is related to increase in length of the middle cerebral peduncles. This will lead to an increase in size of the epidiameter of the fourth ventricle, because the fourth ventricle should have the epidiameter inferior to the transverse diameter. So if you look carefully to the fourth ventricle in axial plane, for sure will get the diagnosis. But it's easier when you have an index case. But if you are in a condition when you suspect Joubert syndromes, because there is polydactyly or ecogenic kinase, you have in ecogenic kinase to go to the posterior fossa in axial to look carefully at the fourth ventricle. Look, you speak about coronal cysts, and do you see any difference between coronal cysts, which are located on the superior and external border of the frontal horns, compared to the cysts which are below the frontal horn?
Yes, well, there is definitely in the literature, some of the papers do differentiate these two entities from each other. I don't think there is much information on what actually is called coronal cysts. Most of the information relies on the suprapendular cysts that are localized more anteriorly. And I personally have difficulties rather to differentiate this on ultrasound scan, because the difference is not so easy to see, I think, and it depends also on the size of the cystic structure. So to my knowledge, we actually now refer this to rather a frontal horn cyst and try to figure out from there in terms of looking for congenital infections and other associated anomalies to type this condition. But actually, we do not differentiate in our center between those two entities.
Thank you.
Do you differentiate?
I prefer to have a cyst at the superior and external border compared to the cysts below, because we found more CMV infection, more metabolic disease when it's below compared to the one who are on the superior aspect of the horn. Maybe it's time to Petra to conclude.
Yeah, thank you very much. On behalf of Canon, I really like to thank our amazing speakers, Dr. Branco, Professor Ducat, and Professor Guibault, for your fantastic talks. And I also like to thank you for your moderation and taking care of the Q&A section so far. It was really, really good. But I also like to thank our audience out there in front of their computers for joining, listening carefully, and improving their knowledge. For now, thank you very much all for joining. Wishing you a relaxed evening, a great day, or even a good night. Thank you, goodbye, and looking forward to welcoming you all soon again. Thank you very much. Thank you.